And so, real quick before we start, and this is just how we do informal mentorship groups. Everybody met everybody? Yeah? Okay, fantastic. So I'm going to keep it not super high level. I'm going to keep it just sort of a cursory review. I will go as high level as you guys want to ask. So if you want to ask about neuroanatomy, if you want to ask about peripheral nerve entrapment syndromes, like, you know, I don't know, the median nerve in the bicipital aponeurosis, you know, things like that, you know, sometimes are mistaken for, you know, bicipital tendonitis, and a therapist is in here rubbing a distal biceps tendon, and it's not the tendon at all, it's an entrapped nerve. So ask whatever questions that you've got. Common conditions that you've seen at the elbow, yourself, so far.
A lot of country club elbow.
One more time?
A lot of
Country club elbow, which means? Hand me the
tennis
model
and
there.
golf.
Okay.
Golfer's elbow.
Yes?
At the same time.
Okay. Both sides?
Yeah.
Wow.
Which was impressive considering this was a person who does not do any sort of like strenuous upper extremity stuff. Like works on the computer, plays video games. That's day to day.
Gamer's elbow.
So they're probably gaming and like golfing.
Okay.
I don't even golf.
Okay. How about you, Jack? Common elbow conditions that you've seen frequently, like most frequent pathologies. Mm-hmm.
Lateral, yeah, golf or tennis elbow.
So lateral medial epicondylalgia. Okay.
Sometimes overusing of teres, pronator teres.
Okay. So overuse of pronator teres, which gives rise to what kind of epicondylalgia? Medial. Perfect. Yeah.
I see a lot of, especially in this area with the work that's being really repetitive, I see a lot of lateral epicondylitis, medial epicondylitis, supinator syndrome, especially with like construction work.
Okay. If it's supinator syndrome, what epicondyle is going to be more irritated?
More of the lateral.
Yep. Perfect.
You pretty much said everything.
Okay. What they said.
Yes.
Okay. Have any of you guys ever had an elbow problem? Does anybody? I know you've had an elbow problem, cameraman. Absolutely. Do you mind if I share? So Marek, our fantastic cameraman back there, has had bilateral distal biceps tendon ruptures. It's the way that he and I got to know each other quite well. And then he's had a triceps tendon rupture. So he's had surgery to reattach his left triceps and both biceps at the radial tuberosity, anteriorly at the distal elbow.
6 weeks apart.
Wow.
Yeah. That's what you get for trying to carry 500 pounds on a barbell. And it starts to move the wrong way, and you try to hold on to it, and pow, tears your biceps off. So, okay, so what I did here was just a super duper high level, low level review of just about everything. You've got your osteology. So how many joints do we have at the elbow? Just off the cuff, how many joints? How many joints are at the elbow? 3. Articulations, right? And so I don't like the way that Google named them, so I'm going to rename them. Go to the arthrology section. Humeroulnar joint. We already know that that's the big, large hinge joint. You know, the distal humerus and the proximal ulna. The humeroradial joint. Humeroradial joint. I learned that as the radiocapitellar joint. Humeroradial joint. You know, the radiocapitellar joint. I don't like that name. I don't even recognize it. So it talks about load transmission through the forearm, contributes to flexion extension, pronation, supination. I call that the radiocapitellar joint, which is, you know, the proximal radius inside the capitulum, okay, of the humerus. So anyway, that's my name for that joint. Proximal radial-ulnar joint, the PRUJ, and of course that's our primary pronation, supination joint. Super easy, you guys. The UCL, the RCL, the annular ligament, which stabilizes the radial head inside or against the ulna, the round circular ligament, and then the musculature, very, very simple review. Flexors, biceps brachioradialis, brachialis, extensors, triceps and anconeus, the wrist flexor pronator group. You've got your pronator teres, flexor carpi radialis, ulnaris, flexor digitorum superficialis, and then wrist extensor group, ECRB, ECRL, ECU, supinator. Real quick before we actually drop down, in general, which of our peripheral nerves innervates our extensors at the wrist? Radial, yeah. And what other muscle, big muscle, does radial nerve supply? Triceps, yeah. And in general, which nerve is going to give us most of our flexion at the wrist? Median, yeah, perfect. Very, very simple. So median nerve passes through pronator teres, remember that? So there's a risk of entrapment there, and if you think somebody has pronator teres syndrome, it might actually be median nerve entrapment syndrome, so something to think about. This is why the upper limb tension tests are so important, to be able to execute and execute well. Is it a cervical spine problem? Is it more proximal? Is it more distal? Is it even a nerve problem at all? The biomechanics, real simple overview. I want to get to the hands-on work, so I'm going to fly through this stuff. Normal range of motion, 0 to 145, extension, about 10 degrees of hyperextension in some people, not me, but some people. You think about your biomechanics, your arthrokinematics. There's the concave ulna on the convex distal humerus. Okay, so you're going to think about your glides and your rolls, and your convex concave rolls, so that when we start to mobilize different directions, if we're doing distraction, if we're doing posterior, if we're doing anterior glide, what is it we're trying to accomplish? Which side of that joint are you going to try to move in what direction? Okay, just so that you can kind of have that picture in your mind. And then pronation, supination. So this is really interesting. Proximal radial ulnar joint, distal radial ulnar joint, both have to couple to allow for full pronation, supination. So if somebody's missing some supination, some pronation, you've got to go proximal and distal at the radial ulnar joint to figure out, why are they lacking, where is it lacking, and which side of that joint, or which end rather of that joint, proximal or distal, are you going to treat, okay? Normal range of motion, 75 to 85 degrees, supination 80 to 90, and very, very interesting, 60% of the load transmission through the humeroradial joint, or the radiocapitellar joint, okay? Interosseous membrane transfers forces to the ulna. So common outpatient pathologies, I think you guys already named every single one of these on the list, but lateral epicondylalgia, extensor carpi radialis brevis, more common than longus, okay? Pain with gripping, resisted wrist extension, and the chairlift test. You guys all familiar with how to test for that?
Not the chair. Is the chairlift? It's just
like literally just like it sounds. Just try to pick that up.
Oh.
Just try to Yeah. If I have a real bad lateral epicondylalgia and I grip like this and try to lift, it's gonna kill me. Okay? It's very, very simple, very, very pathognomonic, for that particular condition. Golfer's elbow, you already mentioned, Brianna. Flexor pronator tendinopathy, pain with resisted wrist flexion, pronation. Okay, you guys all comfortable with how to test those? Fingers, wrist, etc., etc. A little bit of ulnar bias. We'll go over it. Okay. You guys have probably seen, I'm going to go out on a limb here, you've seen ulnar collateral ligament tears, no? Post-surgical repairs, Tommy John, none of those, and a young overhead throwing athlete, like a 16-year-old baseball player. Okay, super common. Okay, they've got neuromusculoskeletally immature arm, terribly weak dysfunctional rotator cuff. They've been throwing since Little League, and they start getting real long and real wide and real lateral when they throw the ball. And you'll look at a slow motion picture, and their entire forearm gets taken back in this awful, awful valgus posture, and they throw right through their UCL, and they usually end up in surgery. Okay, not usually, but frequently, more frequently than we'd like to see. Cubital tunnel syndrome, super important. When the ulnar nerve, okay, gets irritated between the medial epicondyle and the olecranon, okay? And you guys can actually go there with your thumb and you can irritate it yourself. It's very easy to palpate in most people. Sometimes you can, strum it like a guitar string, and your patient will jump off the table and say, ow, or they'll say, God, that feels like I hit my funny bone. Yeah. And you know what the answer is to that, right? What you say to a patient when they say, that feels like I hit my funny bone. And that's why we call this bone the humerus, because it's funny. Yeah. Okay. You ever heard that before?
Oh, yeah.
Okay, good. Thank God. Otherwise, I was going to be like, all right, I'm too old for this.
It's one of those
Yeah.
timeless jokes.
Okay. Deep aching pain in the lateral forearm without true weakness. Deep aching pain in the lateral forearm without true weakness. Okay. Is it radial tunnel syndrome, or is it posterior interosseous nerve entrapment? Okay. We don't know until we test. Pain with resisted supination and middle finger test. Okay. Not the middle finger test you're thinking of. Okay. All right. Swelling, pain anterior elbow, weakness in supination. So we mentioned the Tommy John, the distal biceps repair, the elbow arthroscopies. I haven't seen too many elbow arthroscopies. The elbow surgeries that we've seen in here most commonly are going to be triceps tendon ruptures post-op, distal biceps tendon ruptures post-op, ulnar collateral ligament reconstruction post-op, fractures post-op, forearm fractures, elbow fractures, olecranon fractures with ORIF, usually because of a fall. Worst one I've ever seen, father trying to teach his teenage son how to do a wheelie on a mountain bike, and the father clipped his feet into the pedals and pulled the front tire up and went too far and couldn't get his feet out and landed both elbows on the concrete, shattered them both badly. ORIF bilaterally to his elbows. It was terrible. So Jack, if you want to jump in here at all, let me know. You're going to talk about and ask your patients mechanism of injury, overuse patterns, about gripping and throwing repetitively. Are they having any neurogenic or neurological symptoms? And if so, are they in a median and ulnar or radial distribution? And what does that look like? And then what functional limitations do they have? Okay, lifting, gripping, throwing, carrying, squeezing, pinching, turning, all of those things. Observation, you want to read those for us? The objective exam. This is just observation, not even touching your patient yet, not necessarily. You're looking at carrying angle, swelling, atrophy, alignment. You lost your place, that's okay. And then comparing range of motion bilaterally, assessing painful arcs. You don't have the full detail, sorry. Strength testing, resisted wrist flexion extension, pronation supination, elbow flexion extension. Okay, so everybody, let's talk about elbow exam. Ryan, what joint do you want to concern yourself with? What body region do you want to concern yourself with when someone comes in and says, I have lateral elbow pain? Diagnosis from their physician says, lateral epicondylalgia, chronic. And it's a 64-year-old male who's retired, let's say. 65, 66-year-old male, retired. Lateral epicondylalgia, chronic. And he comes in. What other joint, what other body region do you want to examine prior to going right to the elbow? Because the elbow exam is all here, and we'll examine the elbow, but what else do you want to know before you go and start fiddling around with the elbow? Shoulder, yeah, absolutely. Why? External rotation compensated by wrist extension. Always, always, always. Really, really interesting case comes to mind. He was a former Air Force pilot who years and years and years ago accidentally ejected from his plane while it was parked on the runway and and his chute didn't deploy. And he landed strapped to his chair and just got broken to pieces. And since then has had lateral elbow pain for years. And when he came in, he was seeing one of our then residents who I was mentoring, and he wasn't getting any better. And so when I did a subjective history, what have you had done to your elbow? He says, John, I've had everything done to my elbow. I've had injections. I've had ultrasound. I've had heat. I've had massage. I've had electrical stimulation. I've had dry needling. I've had lots and lots of PT. I said, okay, and none of it's worked? And he goes, well, I'm still here, aren't I? I'm in your place now. And I said, okay, come on over here. Stand, just hold your arms like this for me. Don't let me move you. And I just did a simple resisted external rotation test. Completely caved in, crumpled on the involved side. I said, does that hurt your elbow at all? He goes, no, a little bit, but God, I didn't realize I was so weak. I said, you're very, very weak. Is that your dominant arm? Yes. All we did was strength train his rotator cuff, and miraculously his elbow pain disappeared. So an elbow is not always an elbow. And when you have a patient that presents with elbow pathology, predominantly lateral elbow pain, always, always, always look to the shoulder first. Whether it's lateral or medial, look to the shoulder first. But if it's lateral, absolutely examine the shoulder, okay? Joint mobility, accessory motion, passive motion, active motion, and strength of the rotator cuff. It will tell you a lot as to what's going on at the elbow, okay? None of you said you've ever had elbow symptoms, right?
Oh, actually, I have, just slight tendonitis from studying for so long.
Those heavy books?
Yeah.
Okay.
Well, I mean, also just
Long-term maintain flexion.
yeah, long-term maintain flexion.
Okay.
And then slight.
Okay. So the reason I say that is that you're rarely going to see just an elbow. There's going to be some contributing factors, proximally or distally. So always look up and down the chain. The elbow's caught right in between two very, very important other parts that need some screening, okay? And I'm keeping it this way as far as mentorship today because of you three, okay? It's really, really important, particularly when you start getting exams and evals thrown at you, like, and someone comes in and, oh yeah, you know, I've been playing a lot of pickleball and my elbow hurts. Oh yeah, but I had a couple falls. And, oh yeah, my shoulder kind of bothers me too. It's not just an elbow. It's rarely just an elbow, okay? Okay, so who wants to show me how they would examine an elbow? So we can walk through an elbow exam. You can examine my elbow. Anybody. There's no right or wrong here, remember? This is you know, no holds barred mentorship, whatever you want.
I'll go.
Okay. Thank you for being a good volunteer. We appreciate it. All right. I'm your patient. I'm John. David, thanks for taking care of my elbow pain. How are we gonna knock this thing down?
So I just want to take a quick look at your posture. So,
Okay. You want me standing?
Yeah, let's just take
Okay.
a quick look standing. Okay. Good. Do you mind turning around? Okay. Good. Any symptoms just standing like this?
I got a little bit of a, well, I'll just use this side. I got a little bit of an ache right here.
Okay.
Sometimes some tingling down my forearm.
Same symptoms you came here for?
Mm-hmm.
Okay.
Yeah, it's annoying. It doesn't stop me from doing anything. It's just annoying. It annoys me sometimes. I'm really active and I'm a physical therapist. I work with my hands all the time.
Yeah.
I can't have this going on in my elbow or in my
Yeah,
forearm.
Definitely. That's definitely one of our most prized tools
Mhm.
in our arsenal. Remind me again, what specific activities bring on your symptoms?
Squeezing tightly, and gripping and pulling on things.
Okay. And does that ever radiate down to the hands, or does it stay pretty local?
Like this.
Okay.
Just like that,
So-
achy, deep.
Okay.
Sharp here, achy, deep.
Okay. And then this is the area where it just goes down. Doesn't ever travel to this.
Nope.
Go up the shoulder. Okay.
Mm-mm.
Got it. So let's go ahead and have you go ahead and take a seat.
Okay. Jack, jump in if you think he's off the reservation, okay?
All right. Next what we're going to do is we're just going to take a look at some movement,
Mhm.
and then I'm going to take a look at your muscle strength.
Okay.
See if we get anything out of that, any symptoms that may come up.
Okay.
I just want to see how we move functionally.
Perfect.
So let's go ahead and let's just start from here. I want you to bring your hands palm up. Anything with that?
It's a little irritating back there, yeah, on the outside of my elbow here.
Same area, same reason you came
Doesn't
in here for?
radiate down, just here. Yeah.
Okay, now bring them back to neutral like this. Go palms down. Anything with that? No?
No.
Okay. Now go ahead on this side. We'll start actually on this side so you know what we're going to do. So we're going to go palms up. And I'm going to try to put you palms down. Don't let me do that. So just stay in this position.
Okay.
We're going to start in 3, 2, 1. Here we go. Hold. 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 Okay? We're going to do the same on that side.
Okay.
We're going to start in 3, 2, 1. Here we go. Hold. 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 Anything
Good.
with that? No symptoms?
No.
Okay. Next, what we're going to do is...
Didn't feel like much force though, gotta be honest with you.
Okay.
Now I'm gonna be your mentor. You didn't even turn my muscles on. Like
Okay.
you gotta give me a lot more horsepower than that if you're gonna tap in. You're doing a manual muscle test, so you're only really gonna tap into 40, maybe 50% of a muscle's capacity.
Okay.
And you put very little into that.
Okay.
Like I barely felt any resistance turning my supinators on, you know?
Okay.
And so, here, come around to this side again. So where I might have started is, take me here,
Okay.
grip tight, okay? Try to turn me over. Now I'm working.
Okay. So start with this.
Now I'm working.
Okay.
Okay? And over here,
Try this.
so,
Okay.
and go ahead and you can still do your 3, 2, 1 count, all that stuff. Now try to turn me over.
Okay, we're gonna start in 3, 2, 1. Here
Yeah.
we go. Hold.
And now I'm working. Like that's resistance.
Okay.
And if you're gonna initiate symptoms, particularly from a guy like me, like you gotta you gotta challenge the muscle. Because if it is primary muscular pathology, tendinopathy, etc., you gotta really put tension through the system. And the first one I was like, are you giving me a massage or are you manually muscle testing me? Like you got to go. Any feedback on how you would want to resist?
I just want to mention that, and also have the elbow always stay with the body side, so he doesn't have the compensation open by the elbow.
Yep, I got a little bit out here, but yeah, I mean, you can test real strict in here, but you got to give it a little bit more horsepower than that. Like when I manually muscle test a patient, I tell them, I'm going to try to rip your arm off before I engage. And of course, I'm not going to I'm going to, like the space shuttle takes off.
Yeah.
You build thrust gradually, right?
Yeah.
I'm going to say, okay, hold, David, hold. But I'm really going to challenge you.
Yeah.
Otherwise, you really don't know for certain if that is the tissue that is pathological. You want it to work. You got to put some tension through it. Painful to contraction, palpation, and stretch, it's muscle. Okay?
It's also potentially warn the patient that it might bring on their symptoms.
Yeah, perfect.
That's what you're trying to find.
Absolutely, positively. And maybe before I would manually muscle test somebody with lateral elbow pain, if you're actually suspecting lateral epicondylalgia, some radiating forearm pain, have them actively put it under tension first on their own. Demonstrate for them. Does that bother you? Does this bother you? Does this bother you? Does this bother you? Before you even lay a hand on them, because if anything's going to flare them up, it's a heavy manual muscle test or a heavy deep palpation exam. That's going to flare them up. So if you can do the tests first that are less likely to flare them up and graduate to the manual muscle tests, you might have more luck and narrow your funnel faster, because if that flares them up immediately on manual muscle test exam and they don't want to do any more because they're in pain now, like your exam's done.
So build them up with the least aggressive.
Yeah, but you're doing fine. So this is why we do this.
Yeah.
This is why we do this. You guys are brand new and brand new. And so this is why I want to have these discussions, okay? So keep going, it's okay. Interject whenever you think that he needs some extra guidance, okay? Go ahead.
Okay, so next test that we're gonna do is basically what I call a middle finger test.
Perfect.
So what we're gonna do is we're gonna have you palms down like this. We're gonna raise up this middle finger.
Yep.
And I'm gonna try to push down. Don't let me push. I'm gonna just try to put resistance to it.
Okay.
Let me know if this brings on any symptoms.
Got it.
Okay. 3, 2, 1. Here we go. Hold, hold, hold. Any symptoms?
No, just hard. Why do you
We're
do
gonna
this?
try
Why do you
this
do
one.
this test? What is this test about?
So this test is to help to see if you have a condition called lateral epicondylitis, which is basically tennis elbow.
Perfect.
A lot of, especially with physical therapists, a lot of repetitive activities. So we're going to try to see if we can rule it out. So here we go. 3, 2, 1. Here we go. Hold, hold, hold.
Just hard, but no, I'm good.
No symptoms. Okay, good. Next, what I'm going to do is I'm just going to strum around the area, see if that brings on any symptoms, just to see if I can feel any tightness or any swelling.
Before you do that, may I interject?
Yeah.
So if that didn't bring on any symptoms, how could you load me even more? How could you, if the middle finger test doesn't elicit proximal symptoms at the lateral epicondyle, what test could you then accelerate to or graduate to create way more force through the lateral epicondylar region?
It's the, forgot the name of the test, but you extend the wrist radially deviate.
Give it a shot. So closed fist, okay? It's all written in your outline, but closed fist, okay? Resisted wrist extension with the fist. You can load up here a lot heavier than you can on my middle finger, okay? To see if you can elicit symptoms. So give it a shot. Just resisted wrist extension with a closed fist.
Okay.
Go ahead.
I'm going to try to bring your wrist down. Don't let me do that. Let me know if there's any symptoms with this as well.
Hold here. Give me a good base. There you go.
Okay?
Yeah.
Let's actually bring it down. Here we go. 3, 2, 1. Here we go. Hold.
And
Hold. Hold. Any symptoms?
no. But if I'm a real patient, yeah, that would have hurt like hell.
Okay.
And I wouldn't have been able to give you that much resistance because you really loaded up. I'm proud of you. That was a manual muscle test. That was good. Okay, next. You were going to go to a proximal palpation exam?
Yeah.
Okay.
So I'm just going to take a feel for the area, see if there's any tenderness or swelling.
Okay.
So I'm actually going to demonstrate on this side how it's going to feel. Okay?
Perfect.
So I am going to go pretty deep just
Go ahead.
because I'm trying to really take a feel for the area. Okay. Okay, so this is about as deep as I'm going to go.
Okay.
Just strumming around the area just like this, okay?
And how about right at the epicondyle? You wanna get in right on the epicondyle? Because sometimes if it's insertional, you need to actually be on the bone. Like that's where it's gonna be most tender in a patient that's actually got lateral epicondylalgia. It may not be.
You extend your wrist.
Mm-hmm.
Okay, yeah, right here.
Yeah,
Okay, so we're gonna repeat that on that side.
perfect.
Okay?
Okay.
Let's go palms up.
Mm-hmm.
Okay, go ahead and extend at your wrist.
Extend my wrist.
Yeah, okay, there we go. Okay, you can go ahead and relax.
Okay.
Anything with this?
Ah, right there.
Okay.
Yeah, I didn't like that.
Got it. Okay, you go ahead and extend your wrist now. Anything change with that?
It's a little bit tender. Yeah.
Okay,
Yeah.
got it. Next what we're going to do is I just want to go ahead and see you extend your elbow.
Hmm?
Anything with those?
No.
No?
Mm.
Okay, got it.
Question, because your mind is, I think you're grasping for, what do I do next?
Yeah.
What questions? Where do I go with this? Okay, go ahead. You want to say something, Jack? Go ahead.
I'm going to do flexor strength testing as well because the reason is because most of the patient they're not doing. Some of the patient they do a lot of wrist extension or elbow extension, so they have overusing here. But some of the patient or PTs they do a lot of gripping, flexors working. And when you do the flexor working or the gripping, you're actually having the wrist extensor do an antagonist workout.
Okay.
So
Eccentric work.
eccentric
Yeah.
workout. So you can have the overusing here as well.
Okay.
And in this kind of scenario, you might want to compare the strength in between flexors and extensors. If they do have a big difference, then that might be the problem and the contributing factor. And the other one is that I'm going to check the brachioradialis at this spot because as the patient just mentioned, he can reproduce the symptom by a lot of pulling like this, and this is the brachialis radialis or the lifting. So we want to make sure this muscle,
Is
not just the wrist extensors or the supinator, and you can go up to
Where's that model?
back side of their humerus.
Where's that model?
In between.
See where the brachioradialis dives in and attaches? Okay.
So we want
It's
to
important.
go deep into the in between the triceps and the humerus, so you can target at the fascia here, and that you usually reproduce the patient's symptom. And if you want to decrease or alleviate the problem or the pain, then you can release here a little bit, and then ask them to do anything they were painful before to see.
Also, I'll add triceps manual muscle test, just because if it is a radial nerve entrapment syndrome, and this elbow extensor or triceps is weaker than the opposite side, symptomatic elbow, lateral elbow pain, weak triceps on that side, could this discomfort at the lateral elbow actually be radial nerve? Maybe, particularly if there's triceps weakness on that side. And then if so, we go to a radial nerve upper limb tension test to confirm or refute. Okay? All right,
So,
go ahead.
let's go ahead. I'm going to start with a triceps test. So,
Okay.
let's go ahead and flex the elbow. I'm going to try to yank your arm out. Don't let me do that, okay?
Okay,
Here we
Got it.
go. 3, 2, 1. Hold.
got it.
Hold. Hold. Any pain with that?
Mm-mm.
Okay.
Just some crepitation because I'm old.
No worries. All right.
How about this way?
Yep. Here,
Okay.
mid position for brachioradialis. So the handshake muscle
Yeah.
in neutral. You go.
Okay. Next, what we're going to do is same thing. Don't let me yank your arm out.
So here, you're talking about brachioradialis, right?
Yeah.
Okay, so you just need to stabilize posteriorly here, and your force is just going to be here, and you'll see the muscle turn on immediately. Just try to extend my elbow. There it is.
Don't let me bring it down.
Mhm.
3, 2, 1. Here we go.
Go.
Hold. 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 Anything with that.
Okay.
Okay.
Okay, just hard.
All right. Next, don't let me bring your elbow. Don't let me flex your elbow like this. Keep it out here.
Okay.
Okay. Here we go. 3, 2.
Ooh, sorry, if that's mine, Ryan, just turn the ringer off for me.
Here we go. 3, 2, 1. Hold. hold, hold. Anything with that.
I'm okay. You want to test in mid position too? That was a little awkward to test my triceps in a supinated position. How about just in neutral?
Okay. Here we go. 3, 2, 1. Hold, hold, hold. Anything with that.
I'm okay.
Okay.
Yeah, just a lot of noise.
Okay. So next, what we're going to do is,
So far, ouch, that was painful.
Yeah.
And that was hard, but not necessarily painful. That's where we are so far. It's for your objective findings.
okay.
And ouch to your palpation at the epicondyle. Okay, so you've got palpatory tenderness.
Yep.
You've got contractile tenderness.
Yep.
Okay, not necessarily weakness, but contractile out tenderness. Palpatory tenderness, what's the third component if you actually want to confirm lateral epicondylalgia? What are we going to do versus something else? We're going to, go ahead.
Well, I was saying the special test that I did. So there was the middle finger test, or I think it's called Cousins.
Yep,
Right.
Cousins, yep.
And then I also wanted to do the one where you pronate and extend and radiodeviate. Just forgot the name of that one, but we just basically, well, I mean, we kind of did it with the extended, so.
So what are you thinking so far? If I've got pain with palpation, pain with resisted extension, and positive, irritation, but not necessarily weakness with middle finger test, where do you want to narrow your funnel now? With what? Do you want to stretch? Do you want to do neural tension test? What do you want to do next?
So I will do the stretch first.
Okay, go ahead. Show us. You need that? It's there for you.
Okay, could you do this for me?
Sure.
Would that aggravate any symptom?
It doesn't feel good right there. Yes. Yeah.
Okay, so you feel a strong pull, like a good pull stretch, or is it already make you like feeling?
I don't want to stay here very long.
sharp pain.
No, just a strong stretch from here to here.
Okay, good, thank you.
Mm-hmm.
And then we're going to do a nerve tension test for you to see if I can reproduce the symptom for you.
Okay.
Could you?
wanna lie down?
Your back?
Yep.
Okay. Let me do on your left side first, so you can compare the right
Okay.
side.
You guys see what nerve he's going to tension?
Yeah.
Okay. Radial. Yep.
Okay.
You need me closer
yeah,
to you?
Could you scoot toward me?
Yep.
Could you have your thumb inside your fist?
Mhm.
Yeah.
So he takes up the slack of the shoulder girdle. Okay. Scapular depression first. Okay.
Okay. Relax. Except for the stretch feeling over here. Anything on your left forearm?
No. Okay.
Okay, let's compare to your right side. Have your thumb in the fist. Anything
Yeah. Right there at end range. Woo.
here? It's a real pain or
Painful, very painful stretch,
very
like
small
fire.
stretch? Okay. So it's your familiar pain?
Very.
Very? Okay,
Mhm.
got it. Then, wait a second. Radio, okay. Then I will, so now I reproduce the John's symptom by stretch his radial nerve. So I'm thinking about how's the nerve tension count? Is there any compression from any kind of root pressing the nerve? So I can decrease the symptom by increasing the space for the nerve. Yeah, so I'm going to either check the anatomy map, or you can just memorize all the interface. You can increase the space.
Are you talking about like Tinelli? So like
Well, entrapment
so look for
sites.
entrapments.
Entrapment site,
Okay.
mechanical interface. So mostly they will have the radial nerve being compressed underneath their supinator and their radial brachialis. So I will do a holding like this.
He's just lifting them up.
Yeah, lifting them up. And ask,
Mechanical decompression.
yeah, and ask if John feels better. And if he does feel better, then I will have the taping. Kinesio tape, use the elastic form to mimic my graphing here.
That actually
so
feels
you're
really
just
good.
basically pulling right here.
I am not pulling, I'm pressing here,
Pressing
here, and then grab it, and then you But imagine you're lifting this muscle up to
Okay.
decrease the compressing force onto the nerve.
Okay. So more like this.
Yeah, more like that. Yeah. Yeah, something like that.
Okay.
Okay, so I want to double check again. So I'm going to use the tape here. Let's say we're using the tape here already,
Okay.
and then we do a nerve tension test. If I cannot reproduce the symptom that much, then this is the one of the cure.
Okay.
So could you please help me do a
So he's going to get me in the
Oh.
painful. He's going to get me in the painful position, David. He's going to put the radial nerve under tension, and then you are going to mechanically decompress it by grabbing onto brachioradialis and supinator, and pulling them up off of the nerve.
Okay.
Okay.
could
Yeah,
you do
I
that
know
for me?
what- Oh, right now. Okay.
Okay, and then follow my movements. Let's go down. And we got the nerve being pinched here before. Now, how do you feel?
You're going to have to go further for me to feel anything.
Okay.
There.
Okay, got it. So after lifting the muscle here, we can stretch your nerve even far away. So I think this is one of the contributing factor we can help you. So what we can do at the first session, if we have no time already, then I'm going to decrease the tension by doing massage, and also teach the patient how to do stretch and have the tape on it. Then they can go back do their homework. And if I have more time, then I'm going to check every entrapment site for radial nerve, and then do the same thing again. Yeah.
So where are you anchoring the KT tape? Right here, and then you're just bringing it out, or do you join it on both ends and then lift and then strap it?
Do you want me to show?
Go for it.
Yeah. Okay.
Yeah.
Could you stand up?
Of
Sit
course.
Just curious.
Brianna, questions?
No, but I will just say, like a go-to that has saved me a million times, too, is just poke it, load it, stretch it. Just going into an eval with that.
Perfect.
So it's very shortened, and then the other one is you're
That's
ever like,
palpation, contraction, stretch.
yeah, and if you're ever like, "Ooh, where do I go next?" You can help yourself by just explaining what you found so far to the patient, and that lets you buy time to kind of be like, where do I go next? Just be like, so here's what I found so far, and then the patient's like, okay, I know what's kind of going on.
Okay, so what I'm going to do is I rip
Steve?
the tape like this.
Okay.
So I'm going to distract the tape very hard to 100%. So when it shrink, it will lift up the muscle a little bit.
Okay.
So this is the way, and we usually do it in a unloading posture.
Okay.
So not elbow extension.
So this was flex.
Yeah, and a little bit raise. Yeah, lifting
Mhm.
passively. So the muscle is right here.
So by the time you take it off and you tape it down, it's already lifting
Yeah.
up. Okay.
So
Mhm.
because the elastic tension of the kinesio tape is not strong enough.
Yeah.
So we are going to do 2 or 3 taping here.
Okay.
Cover 50% on each one, and this is for the elastic one. If you do have the Leuco tape without elastic form,
Yeah.
that's very good. So you can have the Leuco tape directly. The way I use it is like I have the tape. Do like this,
Mhm.
and then I push the muscle here
Mhm.
to push it up, and then lift the muscle all the way up, and then I pull the Leuco tape
Okay.
all the way up. All the way up, and then wrap it around. And then I make sure I have the anchor here very
Yeah.
stable. So now if the tape without elastic form, then you will lift it up very hard.
Oh, okay.
And make sure you have a cover roll, which is a skin protector underneath
Yeah.
the Leuco tape.
The little white.
Oh yeah.
Yeah.
Don't put that brown tape directly
No,
on
no,
the skin.
no, no. That's why I have both at home.
It'll take skin off. And that actually feels fantastic. Feels really good. So
So radial nerve and
radial nerve decompression at the elbow. Should that be the pathology that you identify?
I mean, yeah, just based off the special tests they
Mhm.
And given the other special tests with that bias,
And-
those radials.
And so how would you recheck if this is actually the treatment that's going to be effective? Would I, if you actually decompress the radial nerve with this technique, would I present with
Weakness.
less pain?
Less pain.
Perhaps,
maybe-
yeah. Maybe less irritation, the middle finger test, less range with the radial nerve glide. Yes.
Test those measures.
Yeah, absolutely. And ultimately, the patient coming back in and saying, hey, I feel better. You know, whatever that tape thing you did last visit really helped me. It worked a lot. It was fantastic. Joint mobilizations at the elbow. Okay, so you tired?
No, I was thinking.
Okay.
I had to think.
Okay, so
Sure.
humeral ulnar distraction. Okay, who wants to demonstrate humeral ulnar distraction? I'm going to go get my mobilization belt because I like to use a mobilization belt for that.
I've
But
never seen one with.
humeral ulnar distraction.
I can do it. I just never done it with the belt.
Don't worry about the
before.
belt. I'll show
Okay.
you. I'll show you how I do it with the belt, just because it helps really load up. But go ahead and I gotta get that off before it. Oof! I don't actually need it. All right. Humeral ulnar distraction.
Go ahead and lay supine for me, please.
Okay. Go ahead, bud. Jack and I are gonna teach now.
Okay. So basically, I would have them here, right? I'll support here and rest. Rest.
Is your
the forearm
table height
elbow.
okay?
Yeah, this is good. Actually, just a tad too high.
Is it a general mobilization
Just a distraction.
education, or it's relative to your?
No, not relative to my condition. No. We'll just say this is an arthritic elbow. I just wanted to get to some very basic mobilization for these guys today, that's all.
So basically, what I like to do here is just. Can I see the elbow model?
Sure.
What I like to do here is basically at this joint. You know how it's cupped right here. I basically like to think of it as uncupping it. That way we create some space and also help you move better.
Perfect.
So start right here. Basically make like a C grip right here, right where the owner would be. And then I just bring it back here.
So you're taking the proximal ulna
Yeah.
and you're distracting it from the
From
humerus.
the humerus.
Okay. And you coupling it with rotation?
Yeah, just to help it really, because of the direction of the owner.
The carrying angle?
Yeah.
Okay. What do you think, Jack? Do you introduce rotation when you do a distraction of the ulna?
Rarely.
Yeah, me too. It's okay. Ryan, do you feel anything actually moving? Do you feel some real heavy duty distraction? Nice.
So that's how I do it. If you guys
Go ahead,
want to show
jump in.
your
Ryan,
ways.
you give feedback.
All right.
Give feedback.
A lot
Brianna,
of
use the table.
times I like to.
I'm interested to see
Kind of do that up first.
I'm interested to see how you guys do it with the belt.
And
I'm
start kind of
guessing
flexible.
doing a distraction and you create the distraction for. So it's like a
My nails. So if I stab you,
It's fine.
Stab him, stab him.
So I just like to start walking first. And then if that was like tolerable, then going into small doses. Once I start the initial distraction, but I have very weak hands, so I like to use it more of a block than as a.
You're an outpatient physical therapist with very weak hands? Come on, Brianna.
Trying to train it.
You'll be okay.
Anytime I carry something over 50
Jack.
pounds,
Okay.
So,
Humeral ulnar distraction, Ryan. Okay.
so for the distraction one, I usually do hold grip like this, and I now compress the muscle directly and move around to take out the slack so he doesn't feel the muscle compressed. And once I hold his forearm firmly like this, I shift my weight backward.
Yep.
and then do a flexion for him.
You see how his whole body moved?
Yeah.
Okay, and you see how Jack's arms are almost straight and he's driving off of his front foot and he's basically water skiing. He's out here like this and both of you guys were like this, real close, and you were pulling with your arms. Okay? Very hard to produce force like that.
So this way we can create a gapping for the elbow. So basically backward, this track, and then flexion with movement.
Mhm.
I usually do it with the belt. So I wrap it around here, I just go back, so I can do it easily.
Okay, so you don't have to drive to
And that's exactly what I was going to show. You can come in here like this, and you can put the belt across your hands, okay? Or you can just use hands, which is kind of my preference. I don't like anything to distract my hands from being able to palpate or feel. But basically, what this does is it gives me extraordinary leverage. Watch, and you tell them, okay? Just like Jack, you get the slack out, okay? I'm going to sink in through your soft tissue first. And if you guys notice, all of my force is going to come off of my left quadriceps.
Oh yeah.
And you see how much force I can create with that belt? My arms are relatively relaxed. They're just holding on. I'm not pulling with my hands or fingers at all. I'm actually able to palpate. And now, off of my rear foot, I can create the flexion movement that we want and maintain the distraction in the joint. Okay? Oh yeah. What do you mean, oh yeah? What do you feel?
So good.
So good. So good. I got you.
Also starting to go down.
Yeah, that's compression. Sorry. Okay. I was loading up just for... So you guys give it a try. The way that you do that with the belt, we can do this at the tibia and the distal femur. We can do it at the ankle for the talocrural joint. We can do it for cervical distraction. Okay? We can do it for all sorts of things. You put the belt around your body, you place a thumb inside, you come over the top, okay? And it's a figure 8. And now you've got all the leverage in the world to create with your body. Your hands get to palpate and place instead of grip and try to pull and do the work. Your body does all the work. So it's here, okay, thumb, over the top, pull through, figure 8. Okay?
Can I give that a try?
Sure. One more time. Here, thumb, over the top, pull through, figure 8, and now you're ready to go. Okay? Give it a shot. Go ahead. And you may need to adjust it. All of us have different sized bodies.
Yeah. So this, come in like this, right?
Yep, and then slip that hand underneath like this. There, boom. And now your body gets to do all of the pulling and all of the mobilizing.
Is it supposed to be gripped this way, or maybe?
Yeah, I think you maybe need it a little bit longer. There you go. So start with your thumb in here.
Okay.
Okay? Pull. And then slip this one underneath and through. Now you're ready to go. Give it a shot. And the table can adjust, or you can adjust to the table height. Okay? Good. Either you need to drop down or the table needs to come up. There you go. You drive off of this leg, and you know what you're missing? This arm missed inside of that belt. So I'm not sure how you did that. So now in there, pull, and now bring your other hand under. The belt needs to be over both arms. There you go. There you go. As soon as I looked at it, I'm like, something's not right here. So the belt is just to give you leverage, okay? It's not to really, really pull through with your arms. Let your arms relax. Let your hands palpate. Keep soft hands, okay? And line up your vector of force with the joint plane. You got to go down to him or bring him up to you, okay? And you drive off of your front leg. Feel that? Mm-hmm. And now, with the distraction maintained, you can create more flexion range. Okay? Good.
So, when you want to go more into the flexion range, is that when you said you would drop down, or?
You maintain your distraction while you flex.
Okay.
Okay?
So just like this.
Mm-hmm.
So you can distract it more too.
Try to give him a rating compared to how much I was distracting you versus how much he's distracting you. Like tell him he can pull a lot harder, or hey, that's too hard, back off a little bit. Give him a gauge.
Yeah. You can pull more. There you go.
Drive off of your rear foot, David, here when you flex.
Wait, I'm having trouble like driving off the rear foot while flexing.
Yeah, I was gonna say, what,
Jack,
like,
you want to demonstrate?
how do you maintain?
Yeah, because I feel like when I try to
tension?
flex it, then I lose the the traction.
Okay, so go ahead and take the belt off. You might have too much slack in there. Got it?
Jack, your right bicep needs to have the strap over it.
So
Yeah.
start here. There. Your arms need to be inside. So see how my arm is trapped here? Inside the belt, here, over, here, through. There. Now you have both of your arms to pull. Okay? Yep.
Yep. just
Yes,
like that.
yes.
Pull it through.
There you go. Boom. Now you're ready. You got it. You want to give it a try? Okay, that. Is that pad going to bother you? Is it okay? There we go. All right. You guys see Jack's body? Watch his body. Don't watch his hands, watch his body.
You lose a little bit of the traction when you're coming into flexion.
Lose a little bit.
But the distraction is really good. There you go.
More going
So
up.
you're keeping your body back, but just standing up.
Mm-hmm.
Okay, so you're not really going forward. You're just
Up.
going vertical. Okay.
And I think I will keep the distraction force all the time by pushing by my left foot
Yeah.
backward,
Mm-hmm.
and I lift it up by my right ankle.
Okay.
Beautiful. Ryan, you okay?
Yeah.
All right. You want to give it a shot on somebody, or do you want
Do you want an elbow?
to give it a shot?
Sure.
You want to practice the?
wanna practice
I want
it?
to feel it first. If
Okay,
That's okay.
sure.
Try the strap
I
thing?
did try the strap thing.
Okay.
Here, go ahead and
Do you want me to
trade.
just get you while you're on the table?
Yeah.
Okay.
Whichever. So all the way around.
Check length.
Yep. Thumb. Oh, boom, you got it. You want the table up or down?
That's good where it is.
Okay. And again, this belted technique, you guys, you can use for the talocrural joint. You can use for the tibiofemoral joint.
Feeling
Make it bicep.
Drive off your left quad.
Hands.
screw myself back.
There you go. Nice work, man.
Just screw myself back more so that I have like actual lift.
There you go. That's right about the charge. Snap back.
You want to try an elbow, Ryan?
Yes, please.
You can try it on me.
Handcuff yourself.
I know.
Very gotta trust the patient. Or you want to track me.
How's the distraction part?
That's good. Yeah, I still feel it even when you're putting me in flexion.
Okay.
Actually, do a little bit more stretch.
More.
Do you know how
Or
to do a
distraction.
Mills
Yeah.
manipulation?
Yeah, there you go.
The elbow, lateral elbow.
I know, but I'm not using it a lot.
Okay.
Yeah.
How you doing with that?
Good.
How'd it feel?
Yeah, it felt good. I mean,
Got a decent amount?
Yeah, yeah.
Okay.
Pretty. Yeah, actually, pretty good.
Okay. So are you guys okay with very general techniques for proximal and distal? Go ahead and relax there. Radial ulnar joint mobilizations.
P.
Okay. Yeah. Proximal, middle, distal. You guys are all okay with those? Okay. Familiar? We don't need to review.
No.
Okay. Glides. You're okay? All right. Okay. So come on up to sitting. So let's say you've got somebody who's got chronic lateral elbow pain. They've had, scar tissue evidenced on MRI. They've had dry needling. They've had tons of PT. They've had massage. They've done exercise. They've done eccentric loading, but they still have irritation. What technique might we consider an HVLA technique, high-level technique, to really sort of, we'll call it release the radial nerve at the lateral elbow? It's called a Mills manipulation. Okay, and it's a radiocapitellar joint manipulation. You guys ever seen it or done it?
No.
Yeah? I saw you going like this. Is it that one? Okay. So, any history of elbow pathology at all?
I mean,
Other than what we just caused?
yeah. I mean, other than the occasional like tenderness from studying for a long time.
Have a
like,
seat
other
facing
than
that way.
not really.
Okay, so right here on the edge of the table for us, facing that way.
Sitting.
And yeah, and I'll use you as a model too, if that's okay, in a moment. Okay, so this one involves pronation, wrist flexion, and an elbow thrust, okay? And he's got a sleeve on. I would never normally do this with a patient without skin-to-skin contact.
I could take off.
But
the
you
jacket.
sure?
Yeah.
Okay,
It's just,
I don't want to stretch it out. Thank you, it's a nice top.
yes, it is.
Thanks for your help. Okay, very cool. All right, so if we're real loosey-goosey here, and we come in to David's lateral elbow, there is his radial head, okay? You guys can all localize it, you know how to find it? Yeah, okay. You feel how I'm right behind your radial head there with my thumb? Okay, so I'm basically gonna push his radial head forward a little bit, okay? I'm gonna keep him loose at the shoulder, okay? I'm gonna flex his wrist, okay? His forearm is pronated. I'm gonna take him up to end range, okay? And when I get him near end range, I'm gonna kind of do what I call minor final adjustments before that little thrust, okay? Did you get that noise on camera? You must, look at your face. That's funny. And then what I'll do is a little bit of tissue work to kind of calm things down. But that is a really effective technique for the lateral elbow that is chronic, hasn't responded, nerve glides aren't working, tissue work's not working, friction massage isn't working, eccentric loading isn't working, and you're just like, what else can I do for this patient? Do that, okay? Follow it up with tissue work, follow it up with icing, okay? Follow it up with education, stretching, etc., and then maintain the mobility, okay? How's it feel?
It feels nice and loose.
Nice and loose now,
Yeah.
okay? That's a Mills manipulation. Does anybody else want to feel it before they try it on someone? Yeah? Okay, come on over. Why not? I'll do it. It's not a violent manipulation at all. It's very subtle.
I was like wondering. I was like, when is he gonna do it?
John, I'm curious, just because in school we were told hypermobile patients should
Avoid it.
yeah.
Yeah, agreed. Yeah. I mean, if you've got a patient that's, 10 degrees of hyperextension and, you can pronate them passively past 90 degrees, and like, why? This is kind of funny, but whenever I see somebody at the gym, man or woman, and they're in full middle splits and they're putting their face and their chest on the floor and they're coming up and down, I always ask myself, why the hell are they stretching? Why are they stretching? They don't need any more stretching. They're going to maintain it for a long time when they're that mobile. They need to be doing strength training. They don't need to be stretching anymore. Some people need stretching, some people don't. Okay, so there's the head of your radius right there, and I always just like to confirm, okay? A little bit of pronation, supination to make sure I can feel it spinning under my thumb. I'm going to apply a little bit of anteriorly directed force with my thumb. I'm going to flex your wrist, okay? I'm gonna pronate your forearm, and that's how I take up the slack. I'm gonna be careful not to have you too abducted at the shoulder because I don't wanna put too much tension through the neural structures. I just wanna stress the joint. I'm gonna bring it here, and there's the manipulation. It's very, very short amplitude, very, very high velocity, okay? Good? He's shaking his head back there. What are these people doing? Oh yeah, you're right, your history. Okay, how's it feel?
Good. How do we maintain the mobility by exercises?
That's a great, great question. So remember, you're taking the proximal radius and you're driving it anteriorly slightly, and you're theoretically breaking apart fascia, scar tissue, etc. that's entrapping the radial nerve. So I would continue with radial nerve glides. I would continue doing pronation, eccentric loading of resisted pronation. I would do medial lateral rotation at the shoulder girdle to maintain, and I would do lots and lots and lots of stretching. Okay? Mm-hmm. Yeah. You want to try it on me? Or do you want me to try it on you? Try it on you? Okay. Okay. So, here, stay here. Okay. So, first we'll find the radial head. Everybody's anatomy is slightly different, so always, always, always check, recheck, make sure that you are where you think you are. There's Jack's radial head. So a little bit of wrist flexion. Notice I'm not too abducted. I'm going to be down here. I'm going to take you to end range, apply a little bit of anterior directed force. There, subtle. Didn't get quite as loud a pop with you, but we got a little one in there. You've got really good mobility.
Thank you.
You're welcome. Okay,
Thank you.
you're welcome. Easy. You want to give it a shot, or you're like, no, hands off me, don't touch. You want to try it on somebody? You want? Oh, you don't need it.
I would like to try it.
Sure. Pick somebody. Anybody. I'll volunteer.
I'm going to take your arm.
Mm-hmm. And adjust the height of the table if you need it. So pronate, supinate me a little bit, and you should feel it spinning right underneath your thumb.
So here.
And so you need to take me into a little bit more wrist flexion. There you go. And then you need to abduct me and elevate me just a little bit, because you're going to force this forward as you take up the slack in my elbow into extension. Okay, and then at the very, very end there, once you get to what you feel is end range, okay, and go ahead and play with it. Don't thrust yet, but pull, 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 pull. Okay, can you feel the end feel there? Does it feel muscular? Does it feel hard? Okay, perfect. So now bring me into a little bit less abduction and go to the end feel again. Does that feel like you can get a little further at the joint? Yeah, because you took out all the tissue slack. You don't want any tissue slack in here. You want it to be all joint. You're closer to all joint now. So you could thrust here, but if you had me up higher like you did before, it would have hurt a lot because you would have really been pulling on a ton of tissue. Now you've got mostly joint. So now go ahead whenever you're ready. Real firm grip with your right hand. Real firm grip with your right hand. Okay? And don't be afraid. You take me up to end range, and the thrust is subtle but fast. Small range but fast. Not bad. So what happened was you lost your thumb at the radial head, and you pushed at the back of
So
my arm with your web
question,
space.
yeah, is for like a better grip, because I feel like this is just very small on that spot. Is there a different hand position that I could take to kind of better?
Have a seat. Let me play around with that. It's a good question. So if I was going to set you up, my setup would be right there, and I would thrust you from here. So I think if you're asking for a bigger hand hold, maybe something like that would work for you. Okay, but then you don't have the benefit of being right. Yeah, exactly. So you'd have to be really careful. You might have to come in here just to make sure that you didn't really abduct the shoulder. You might be able to do something like that. But I would really just commit, and here is where you want your force. And what you did, you took me to here, which was great, and I felt this fine. And then when you thrusted, you went, and you pushed with that instead of with that.
Okay.
Okay?
Okay.
You had it, yeah, of course. You had really good fixation, and then you lost it. That's all. I'll do my best to loosey-goosey, relax, give you my arm. Remember, guys, this is kind of a technique of last resort. You know, it's popular, it's relatively simple, but it's not what you would go to right away, of course. So, doing great. Take up all the slack. Wrist flexion. There you go. Not bad. We'll have to work on your speed.
Yeah.
But that's all. Your fixation's good. End feels good. Speed, a little slow. That's all. Takes practice. Okay? Yeah. Did you guys practice? You're practicing. Good. And that's perfect, Ryan. You can always do it in standing. You don't have to have the patient sit. There's nothing that says you have to have them sit.
Coming up a little bit, or just coming from?
Just go to end range. Here, fix more, push more.
Do you mind if I try on your left?
No, not at all. No, here. Here. Not at all.
I'm just gonna pronate.
Mm-hmm.
Just like
Oh.
Everything's very tight.
Oh, okay.
You can just like slow back.
So if I'm a patient, I'm already pissed off because you're really killing me with that palpation. I would encourage you to go light hands, and a lot more feel instead of so much pressure. You don't have to push that hard. You can feel that spin of that radial head relatively superficially with very light pressure. You don't need to jam your thumb in there. Okay, that hand needs to flip over. No, the other way.
Yeah.
There you go. And you're going to take me into wrist flexion.
I'm just taking a feel for movement.
Okay.
Trying to see the end range.
A little bit more wrist flexion. Control. There you go. And move your leg out of the way. There you go. There. That was actually a pretty good infield right there. Right? Yeah, you're getting there. You felt it a little. You started to go. And then so you get it right there to that very end. And remember, your thrust is tiny but fast. So go all the way to end. Don't lose the tension once you're there. Thrust through it at the end point. Okay? Not bad. You pushed hard with this hand, but you lost the speed here. So go all the way to the end. Don't thrust yet. Just take me up. All the way to the end. A little further. There. Stop right there. That's end range, or very close to it. Your thrust is that much more, but fast.
Okay.
Better. You lost the thumb a little bit. You pushed with your web space, and you hyperextended my elbow. So I felt that right at the olecranon, because you jammed my elbow straight real hard. That's okay. You know. Here, show you. I did your right one, right?
Yeah.
Previously? Okay. So in this position, opposite elbow, again, here's your radial head. Okay. We're going to take up the tension just behind it. Okay. I'm down low. And end range. There. Okay. It always makes you smile, doesn't it?
Yeah. Well, his face. I'm watching his face.
It's not that bad. It's really not.
You'll hear it.
I don't plan on it.
Biggest sound ever heard in my life.
I don't plan on it. No. Great job. But did you see how fast?
Yeah.
And
I think I just need to do it a lot quicker.
and be sure that you're at that end point before your thrust. Otherwise, you're still thrusting through a whole bunch of passive motion, and you don't really have the joint locked near where it needs to cavitate. Okay?
Yeah.
Hopefully that was decent for our first elbow review.
Oh, yeah.
Thank you.
Okay, Jack, thank you for helping teach. Thank you. Yeah, absolutely.